pain, and Linda's going to chime in whenever she wants to. And so whether or not it's driven by a musculoskeletal issue, meaning muscles and joints and ligaments and tendons, or a nerve issue, or even just a coordination or a motor control issue, there are different sources of pain. And part of the therapeutic process is figuring out which of those contributing factors is the most significantly contributing to the pain that you're experiencing based on how it behaves. So, do you want to list, are there any other ones? We said muscles, joints, tendons, organs. So sometimes it can be visceral in nature. So you have the uterus, the ovaries, the uterine tubes, for those with male anatomy, the prostate. So lots of different areas that pain can come from.
Yeah, and I think a couple other things to touch on is also psychosocial and a little bit of emotional, right? So a lot of the times when we talk about pain, we also want to be able to think about things outside of what could be the driver. There could just be, whether it's trauma, experiences that really kind of preclude us to those painful events. So that's something that, you know, we either bring up in clinic or something we ask and may refer out to a counselor, a therapist, or someone to talk to just to get a handle of that. As well as we talked about organs that are internal, but also organs that have been removed, right? Someone that may have had a hysterectomy or prostatectomy or even testicular removal or anything of those things, what I think a lot of the medical field would call phantom pain, right? Mm-hmm. So that also can be a driver of what's going on and what's causing the pelvic pain.
The main thing about pain in any part of the body is that it doesn't become pain until the brain perceives it as pain. So you can have pain in response to a perceived threat. Mm-hmm. You can have pain in response to a recent surgery. You can have pain in response to a recent trauma. Maybe you fell, sprained an ankle, whatever. Those signals from the tissues, whether or not there's damage, there doesn't always need to be damage or structural changes to tissues for there to be pain. And some structural changes are small, like a paper cut, but they hurt really bad. So the amount of pain isn't always correlated to tissue damage. What drives pain is basically your brain's perception of a threat. And it's your nervous system trying to protect you from that threat. So when it comes to pelvic pain, a few common things that we work with are people who have pain with intercourse, people who have pain with bowel movements, people who have pain with going to the restroom to empty their bladder, and sometimes pain with sexual function as well. So that can be erection, arousal, or ejaculation. It can be during intercourse, it can be after intercourse. All of those are forms of pelvic pain. So what can we expect for treatment in physical therapy for things like pelvic pain? So the research that we discussed earlier this month was about manual therapy for pelvic pain. And when it comes to manual interventions, people usually think of massage, which is true. That's a form of manual treatment, but we can also address different tissues in the body depending on each person's anatomy and what's going on. So what can we expect from PT treatment?
Well, I think really, truly it comes down to what the patient or the client coming in is willing to do and not, right? So we have a plethora of tools in our toolbox, and it just comes down to what fits for the person at the time we see them. So we talked about manual, where manual, theoretically, we're saying anything hands-on. It doesn't necessarily have to be massage. It could be a component, but we can look at different aspects of the body, whether it's your hips, if they're super stiff, if there needs to be some more mobility, more so, because when pain is elicited, the body goes into fight or flight, which theoretically puts us into a very stiff and flexed position, right? So do we need to kind of first lengthen that? A couple things is, and it kind of ties into our next question of internal exams, right? But there are other things. If a person's not ready for internal, we can do a lot of external based things. There's something manual wise, we can talk about palpation, or if we need to work on external tissue. But then there's also biofeedback, which I tell people is like a EKG in a video game for your pelvic floor. Everything's external. We hook you up to, it's 3 electrodes, it's all external. We hook you up to a computer. And from there, we get to see the the muscle activity. So we have different positions. We talk about, is the muscle tone firing very high when you're just sitting here talking to me, or are we having, are we able to lengthen it as you do certain things, right? And it's kind of fun. I call it a video game because, again, you have different things. So with that, that's more, and biofeedback can be internal and external depending on what the patient may need. A couple other things we talk about is stability versus mobility, right? Sometimes we think about pain being this big looming cloud and we don't want to strengthen anything more. But sometimes the pain could be because everything is contracted and moving forward. So looking at hip mobility, is it your back? Is it everything else that's connected to the pelvis? Is maybe what we look at first, right? So the approach most of the time is more global, the bigger outside stuff to in. So we don't have to necessarily start with an internal or something of that nature. It's more so so that we can be able to assess things and really get to know each other first, right? We talk about like, maybe buy me a drink before we have this conversation. So again, it's a little bit of getting to know the patient's body, getting to know your PT, and going back from there. So then other expectations for PT treatment, we will talk a lot about whether trauma or anything of that nature, bringing those things up and having resources for patients to have someone, an outlet for someone to talk to.
Just mute it. That works. Can you mute your computer?
Yeah.
Okay. So a big question that we get is, are the internal treatments required? And like Linda was saying, there's so much more that we can also do outside of the pelvic floor externally, whether that's the spine, the hips, the low back. Sometimes we still even treat knees and shoulders, because if we're having postpartum people coming in and they're breast or chest feeding, they also can experience lots of upper back and neck pain as well. So that's something that we don't also dismiss, but everything is connected. So when you think about pelvic pain, the pelvis is attached to all these other body parts. So when it comes to internal exams and treatments, are they required? Absolutely not. So it is always up to the patient whether or not they prefer to have an internal exam done. It is one of the most accurate, best ways to assess the pelvic floor, to treat the pelvic floor directly, and to address any internal issues, whether that's with the muscles, the connective tissues, or the organs in there as well. So they're not required. They're recommended, but it's always up to the patient whether or not they want that done. So if you're somebody who's not comfortable getting an internal exam or having internal treatments done vaginally or rectally, you don't have to. There are so many other things that we can do. I'm not sure if Linda had mentioned, aside from the manual treatment, we also incorporate therapeutic exercise, stretching, strengthening, lots of different modalities to help with pain outside of hands-on treatment. Some people, honestly, when they first come in, their symptoms are so intense, they're so severe that their sensitivity to touch is so high that it causes more pain. So it's not really even appropriate to be hands-on with certain patients, depending on how severe the pain is. So no, internal exams and treatments are not required, recommended because of how beneficial they can be, which is proven in the research, especially when you use those hands-on techniques in conjunction with a multidisciplinary approach, meaning your pelvic PT is contacted by or through your referring physician, hopefully, or if you had a surgery, we're in contact with your surgeon so that we're all on the same page regarding treatment. We also, when it comes to pelvic pain, we talk a lot about behavioral issues. So behavioral things that you do in your routine, your job requirements, your home life, right? If you have toddlers and you have lots of kids that you have to help physically, right? Bending, squatting to help them accomplish whatever they need to accomplish. all of those things matter because all of those things put a different level of strain on the body. So we look at those things. Are you experiencing your symptoms with certain functions or movements? How can we help you get that better or do that better, accomplish that better in a way that's less painful? So think of any other painful area in the body and how physical therapy could help that. That's what we do for pelvic pain. It's just that the functions involved with pelvic pain, which are bladder, bowel, and sexual function, those are the functions that we're trying to optimize. So while the questions might be different, right? We ask about bladder habits, we ask about frequency and urgency, we ask about your sexual health and your sexual preferences because we're trying to help you get back to those specific activities which are very private and intimate. But the methods of achieving that are the same as with any other part of the body, right? You sprain an ankle, you got to let the joint calm down, get the swelling down, get the inflammation down. Then you got to get the joint to be mobile and get the muscles to be flexible again. Once you restore that, then you retrain the ankle, right? You start walking on it again without any assistance, no crutches, no boots. Then you start to learn how to jump and run and sprint and all of those things that come after the healing process. So with pelvic pain, pain is the symptom and we're trying to relieve you of the symptoms. But the long-term benefits of the therapy are that you learn what your triggers are and what your drivers are, and you have strategies to manage when those triggers come again. Because everybody is liable to go into some kind of relapse in their symptoms, depending on lifestyle, right? Habits, life changes. So yeah.
Yeah,
And
that
then
brings
I
up a
think,
really good point.
yeah.
Of another big thing I think we haven't really touched upon too is how the nervous system really kind of governs a lot of pain, right? Like you had mentioned above, pain is a reaction to an external stimulus, whether it is threatening to the body, like what you had noticed that it's threatening. So first is we look at all the physiological stuff, but also understanding, okay, what are the triggers, and then being able to kind of bring those triggers out of the dark and having those conversations of how it became a trigger and how to modify and strategize to come about. So a lot of it is too breath work, right? I think there's a lot of talk about breathing and how breathing really kind of calms the nervous system. I always kind of bring it back to when someone's having like a panic attack, you give them a bag. I never understood why, but it's because you want to slow down the breath, right? If not, it's a quick breath and people get very lightheaded. When they get very lightheaded, it's this cascaded domino effect of imminent threat and imminent fear. Versus can we do a little bit more breath work that's slow tempoed and controlled so that the nervous system kind of dials down, and then we can get a clearer like thought of like, okay, what's happening? We can assess. And then with the assessment for that part with PT, we talk about, okay, you've assessed the situation. What are the strategies that I've learned or that we've worked on that can help decrease that feeling, right? And then from there you move forward.
I think the other thing is subjectively when somebody comes in with pelvic pain and we're trying to sift through what are the drivers or the causes of the pain, a lot of it can be habit or habitual, because what we talk about a lot is pelvic floor tension. And usually when there's pelvic pain, the muscles tend to be overactive. Muscles are not overactive for no reason. And so usually they're overactive because it's a response to pain or the anticipation of pain. But sometimes if we're constipated or if we're holding our bladder for too long because we don't have the convenience of a restroom, or maybe we're just so caught up in what we're doing throughout the day that we don't go often enough, our muscles are working to accomplish that. And so even when your pain isn't triggered, say your pain is with intercourse and you're not having intercourse, but the pain is still present and you want to know why, sometimes it's because of the uniqueness of the pelvic floor's functions. There can be some crossover. So you might have pelvic pain with intercourse, but if we're not looking at and addressing and asking about bladder habits or constipation is a huge underlying risk factor for pelvic pain because of how much pressure it puts in the pelvic cavity and on the pelvic floor muscles. So when you look at those kinds of contributing factors, the treatment of pelvic pain directly would be manual treatment, exercise, movement, and all of that. But when you look at us actually trying to figure out how to get an overactive muscle to become less overactive, you have to address those other factors, those lifestyle factors. And then on top of that, sometimes the pelvic floor very commonly compensates for weakness elsewhere in the body. So if we're not looking at how those muscles are coordinating with your abdominal muscles, your hips, your glutes, right, your spinal stabilizers, right, the muscles in your low back, then typically we see the pelvic floor trying to either help too much or not help enough. And then you have other symptoms. So while overactive pelvic floor muscles may be a very common sign of pelvic pain or a very common finding in people who have pelvic pain, the treatment of overactive muscles, while it benefits greatly from manual therapy, is also addressing why a muscle is overactive in the first place. Hopefully that makes sense.
Yeah, it definitely brings up a good point in the sense of, I think the one way I explain it to patients is whether you're right hand or left hand dominant, you've signed your signatures thousands of times. You can do it in your sleep, right? But then if I give you a pen in your non-dominant hand, you know exactly what you need to do. You know exactly the pen stroke, but it just isn't as smooth, right?
Mm-hmm.
So being able to figure out why and understanding, okay, is it a specific movement? Like you said, is it because of constipation that the pelvic floor is having to hold on to so much because of the downward pressure? And that's the only time per se that we feel that we're squeezing per se, or something's overactive. But then we don't realize how it relates to your day to day. If you're walking around with that and you're having urgency and all those things, but you can't go, your pelvic floor is holding, and it goes, okay, well, you still have to do all of these other things, whether you have children, whether it's for work or lifestyle or recreational activities. And it's a learned behavior that your body now normalizes, right? So coming in and all those questions that we may talk about is just to be able to kind of sift through those things to be like, okay, if we can kind of alter this at this point, does that change? And how does that slowly start to unravel the source?
Right. Yeah. And so when we think, I'm going to jump really quickly to the last question, which is what are some common diagnoses of pelvic pain? Because when you look at the diagnoses, they're basically named for the structure that people think is driving the pain. So when you think of pudendal neuralgia, that's irritation of the pudendal nerve. The pudendal nerve is in the pelvis, and it travels very closely to the pelvic floor muscles and some of our other structures in the pelvis. So while the nerve might be causing the pain, you have to also look at what is irritating the nerve versus something like sciatica, right? If somebody comes with sciatica, that just means that something with the sciatic nerve is happening. Is the sciatic nerve itself the problem, or is it the tissues and structures around it that are compressing it? Then when you hear of things like vulvodynia, right? Vulvodynia or vulvar vestibulitis is a symptom or a condition where the pain is localized to not the internal vaginal area, but just between the labia. So these names, these terms are really just specifying the area and the anatomy of what could be contributing to the pain, but the treatment is still addressing all those things that we just said. So we have to look at the pelvic floor, we have to look at the abdomen, we have to look at the hips, the trunk, the spine, etc., because it all plays into the bigger picture of how this person, this individual, is experiencing that pain. So don't get too caught up in like the scientific name of these things. They sound scary, they sound intimidating, but they're just naming the anatomy where we think the pain is coming from. But because nothing in the body exists separately, right? We're not like a bag of skin, and then here's our organs, and then here's our skeleton. No, it's layers, like everything is connected. So while you might blame one specific nerve or one specific muscle, it's still working within the whole musculoskeletal and nervous systems. So we have to address all of those factors. So if we're going to talk about treatment techniques, we can discuss internal versus external. So Linda has a pelvis behind her, so she wants to grab that. We can walk you through. You want to talk about the external technique? So what we can do outside of the body, or should we start with internal?
Let's go outside in. I think we mentioned it. So just really quickly, female pelvis. I think this is centered. So female pelvis, okay, so if the person sitting here facing you, this is front of the pubic bone, top of your hips, this is the spine, right? Now, if this person lays down, I'm just hoping like the uterus and the bladder doesn't fall. if this person lays down in a female anatomy, we have 3 openings, right? You have your anus, your vaginal canal, as well as your urethra. In males, we have 2. We have your urethra as well as the anus. Now, with external technique, we're really looking at palpating, which means essentially we're just going to touch externally, whether it's with clothes on or not, okay, for patient's comfort. We just want to see, okay, does this bring on anything? Is it familiar to you? And then what we look at from a clinical perspective is, from a lack of a better way to say it, how squishy are things, right? Like, is it giving me some resistance where I run into it and I go, oh, that's stiff, right? Or is it really kind of nicely rebounding where I can get in and out without any symptoms and it's moving nicely? So mobility as well. We also take a look at how it moves, right? We'll ask, okay, can you do me a favor? Can you squeeze? We just want to see, okay, how coordinated is everything? And when you need to bear down to have a bowel movement, what does that look like? This gives us a preliminary look as to what the habits are. Okay, so looking at all those things, as well as external palpation, your hips attach through here. So again, we can also palpate glutes. We can look at hip range. Your abdominal sit up top. And again, if
scar tissue, right? C-section incisions, laparoscopy incisions, myomectomy incisions.
Yeah,
all
or
of
if
that affects
fibroids,
happening.
or it's just like insidious pain. They're like, oh, I have a fibroid on this side and this side's been bothering me. We look at, okay, the neighboring structures. Is it the fibroid that's causing the pain? Or we talk about, like you said earlier, are we blaming the fibroid because it's somewhere that doesn't need to be? Or is it bothering and disrupting kind of the natural habitat?
Yeah. And then if you turn the pelvis around, right, then you have other joints back there that can also contribute to pain. You have your SI joints, your sacroiliac joints on either side. You have your spinal joints, your segmental spinal joints. Then you have your tailbone at the bottom, right? And look at how many things attach to the tailbone, right? Those are all pelvic floor muscles. And you can see how constipation, if those muscles are constantly clenched, or even the opposite, explosive diarrhea, loose stools, you're always kind of clenching those muscles to hold that in, right? And that's pulling on the tailbone, that's pulling on the structures around the pelvic floor and around the pelvic girdle. So that's why we can do a ton of other things externally without going internal. Now, if we were to go internal, I have a little finger puppet. So this is what's inside. It's a schematic of what's inside the pelvic bowl. So if I flip this upside down like Lynn does, right, there's the vaginal opening, and right underneath that is the anal opening. So if we're doing an internal exam, so say this is external, right? This is my pelvic floor facing you. And then you take a look from the inside, right? So now I'm doing an internal exam for you, right? My hand would go straight into the vaginal opening. And from there, if I turn side to side, I can feel a lot of these muscles, right? So there's layers to the pelvic floor. There's technically 3 layers. These ones are the deepest layer, right? So that's where we would go internally. And as you can see, we can go vaginally or we can go rectally. Rectally, we can get right on top of that tailbone. So if we need to do any adjustments to the tailbone, we can get right on it there through the rectum, right? And then the superficial muscles, externally, we can just press on them through the skin, right? Perineal massage is something that we teach a lot, especially if you're postpartum and you happen to have some tearing during vaginal childbirth. And that's right in the middle between where the vaginal opening and the anal opening there's a bridge between there that's called the perineal body. Sometimes we just apply pressure there, very light pressure, just to work on any scar tissue that may have occurred there, which can be a very big source of pain. So we can assess these muscles externally. We can go directly on them. We can go internally, right? We can check each side. We can compare side to side if there's trigger points on one side versus the other. We can even get to the wall of the pelvis, which is a hip rotator muscle. You can see it on Linda's side, right? It's that inside towards the front of the pelvis. It controls one of the hip muscles. And that can be a source of pain for some people too, especially if you have previous hip injuries or hip surgeries. So if we're not able to go internal because of preference, because of comfort level, maybe you're on your menstrual cycle and you're not comfortable doing that, that's completely fine. We can do so many things externally as well. So that was just to give you guys a general understanding of how internal treatments for pelvic floor physical therapy go when you're coming in for pelvic pain. But again, not a requirement, not, it's up to the patient every single time we ask for
Always.
consent. So if you're experiencing pelvic pain, just know that there are several factors to sift through, and that sifting through those factors are what's going to help determine what's the best course of action for you, because your pain is definitely not the same as somebody else's pain, even though they're similar in nature and location. Everybody's perception of pain, their memories of pain, their experience with pain is very different. So yeah, I mean, anything else you want to add, Linda?
I think the one thing worth mentioning, we talked about multimodal, right? Being able to be in contact with the referring physician or the surgeon is hormones, right? A lot of the times we look at, it's out of our scope, but again, we look at tissue because hormones, your estrogen and your testosterone levels really drive your genitalia. So if we look externally at tissue and we're like, oh, it's a little red, is that what's disturbing some of the symptoms, right? So we may refer back. And, we have a conversation with you as well as a call to the referring provider to be like, hey, this is what I saw, what do you recommend? Or I'm sending the patient back and, let me know how we can best work together, and then the provider will decide on what is needed, whether it is a blood test or whatever it is, to make sure it is hormone based or not hormone based.
That's a good point, because I think right now there's a lot of movement towards natural healing, no medications, no surgeries, which is great. That's a great goal for a lot of people. It's usually pretty doable. However, for some people, it's just not enough, and some people need a little extra help. So there's no shame in using medication. There's no shame in needing a surgery. Wherever you are in your phase of healing and recovery with whatever you're dealing with, we're there to support you. And so whether that's pre-op, post-op, maybe you want a surgery, maybe you're trying to avoid a surgery, we have a pretty decent network of physicians that we work with, physicians and surgeons, and they're all pretty great. And so when it comes to understanding what is within our scope as physical therapists and what is a situation that requires a little bit more medical management, we have that ability to go back and forth with your physician, physicians that we have relationships with that trust us with their patient care, to determine if maybe there's additional benefits to using topical lidocaine or vaginal suppositories or changing up their pain medication regimen. Those things, we don't prescribe meds as physical therapists. So we have to work together with your other providers to make sure we're optimizing all of the treatments from all aspects, and that we're not, I don't want to say butting heads, but doing something that's counterproductive to another provider's treatment plan. So we just want to make sure we're all on the same page with that, which is why, if you haven't signed up, next Wednesday, we moved it because we didn't realize today was the inauguration. We will be interviewing 2 experts in pelvic health. So one is a urogynecologist and one is a physician who specializes in sexual medicine. So Drs. Jocelyn Craig and Dr. Erwin Goldstein will be joining us next Wednesday at 5 p.m. on Zoom. So if you're interested in hearing from a few experts in this field, what they do for pelvic pain and how we work together with them, make sure you sign up to receive that link. It's on the Women's Advantage Instagram page in their bio and on our Facebook. So join our Facebook page if you haven't.
Awesome. So if you guys have any questions, you guys know where to find us. Leave some comments on either the Instagram page, DM us, or leave it on Facebook. And then we can go from there. But thanks for your time.
We'll see you next week.
Have a good one. Bye.
Are we done?